So we now have 3 covalent BTKis approved in all settings for CLL, and first ibrutinib, then Acalabrutinib, most recently Zanubrutinib. There's non-covalent BTKis coming down the pike, most notably pirtobrutinib, which has an approval now in the mantle cell lymphoma space, and due to its rating and NCCN guidelines can be obtained off-label in the setting of relapsed CLL, having seen one of those prior covalents. Nemtabrutinib is also probably the other one that's furthest along in development, but without any label approval is not something you're going to be able to obtain off study. As far as the covalent BTKis, these we've kind of said they're all at least equal in efficacy, and the latter two showing in head-to-head data in the relapse refractory setting, but often kind of extrapolated to the frontline setting, reduced toxicities for Acalabrutinib in the ELEVATE-RR study, and then Alpine study showing Zanubrutinib have not only decreased toxicity, but also some improvement in PFS. So I think more to come on that. Right now, the way that I think people are using these in the community is, and my approach is, if you're already on ibrutinib and you're tolerating it well, and you're not having any of these toxicity issues, I'm certainly not taking people who are currently taking on ibrutinib and having a nice response and tolerating it well and switching them over to one of the newer agents. However, if you do have toxicity, I certainly have a lower threshold, knowing that there is some small studies, but prospective studies showing that you will often get a lower rate of recurrence, or if it does recur at a lower grade toxicity, if you stop ibrutinib and then go to Acalabrutinib or go to Zanubrutinib, or even some limited data presented in the last year of stopping Acalabrutinib due to toxicity and transitioning to Zanubrutinib, and either not having recurrence of that same toxicity or having it occur at a lower level. The other thing that I think is interesting that we didn't quite realize, previously perhaps, was when you stop the drug due to toxicity, they may not need to immediately go to the next line of therapy. And this is the data that I'm kind of referring back to here. Comes from longer-term follow-up from E1912, which was ibrutinib rituximab versus FCR. So yes, these patients got an anti-CD20, and probably most people are not giving an anti-CD20 with a continuous covalent BTK inhibitor in the frontline or relapse setting. But the point being is that there was a cohort of patients there who stopped their ibrutinib due to a reason other than progression, so namely toxicity or patient preference or whatever. And it was about 2 years before the disease progressed and they were going to need therapy again. So it's not a given that just because we think of this drug as a very strong arm on the lid that's controlling the disease very well without necessarily squashing it down and delivering these MRD type remissions that you see with venetoclax based or chemotherapy based in the past. It's more of a strong arm of control. It's still not necessarily true that if you take that arm off in the setting of disease stability, or when you're stopping it due to a toxicity, that you'll immediately need to reach for something else from your toolkit to put back on.